Airway management. We discussed in the last talk that a patent airway right from the nasomaxillary, hypopharynx, pharynx, larynx, and trachea takes a precedence over the entire situation. Also, central nervous system depression may alter the breathing pattern. But more importantly, the availability of oxygen to seriously injured patients is mandatory. The first step is in airway management is identification of potentially life-threatening maxillofacial or neck, laryngeal or chest injuries. Well, when a consultant refers to a definitive airway, he means endotracheal intubation or a surgical airway that is supplemented with oxygen, thus providing an airway and preventing aspiration. Patients may suddenly begin to vomit either because of IV antibiotic or maybe under the influence of alcohol or gastric contents. In that case, the patient's head should be turned on to the lateral aspect and a kidney tray needs to be provided. Aspiration remains a danger in trauma patients. Neck trauma may directly affect the airway by injury to the larynx, trachea, or indirectly affecting the airway by vascular injury and an expanding hematoma, probably. In either case, after intubation attempt, a surgical airway needs to be established. Although tracheostomy is one preferred by all, but some may even advocate cricothyroidectomy as an option. Hard signs including abnormal breath sounds, tracheal deviation, labored breathing particularly, which may be found in a complete cord transection, and diaphragmatic breathing. Pulse oximetry is used to detect hypoxia. It shows oxygen saturation, which serves as a good indicator. An arterial examination of the blood, that is ABG, from the femoral artery may require to increase surety. Soft signs for airway obstruction are like we observe the patients whether he is agitated or obtunded. Both these signs in their extremities signify airway compromise. So after checking all the equipment like the suction, oxygen, bag mask, pulse oximetry, intubation kit, etc., the first step is to oxygenate the patient with a bag mask device. Occasionally, oropharyngeal or nasopharyngeal intubation may be required. Airway is required, however, if the patient is conscious. The use of it may induce a gag reflex, which may in turn cause vomiting or aspiration. Then the jaw thrust and the chin lift maneuvers are carried out. Before intubation, it is vital to predict the ease of intubation based on the Lemon mnemonic, that is L for looking externally for a small mouth or a facial injury, then evaluating, E standing for basically evaluating the 3-2 rule for knowing the oropharyngonasal laryngeal axis, like 3 fingers between the patient's incisors, oral axis assessment, 3 fingers hyoid and chin for oropharynx, and lastly 2 fingers fingers between the thyroid notch and the floor of the mouth. M stands for the Mallampatti's classification, that is in short based on the visibility of either the tonsillar pillars, hypopharynx, uvula, or only the hard palate respectively. O standing for obstruction of the pathway that may be anticipated in a trauma setting. N stands for neck movement, which we do not check actually in reality, but it may be important to ask the patient if he is suffering from any neck movement conditions like ankylosing spondylosis, for instance, that may cause a difficult intubation. Alternatively, sedatives that we use are either diazepam or midazolam. They are used as an adjunct. However, we almost never ever use muscle relaxant. If intubation is difficult, a laryngeal mask airway or a laryngeal tube airway may be used to pass blind endotracheal tube and ventilate the patient. The benefits are that these devices are supraglottic and do not require visualization of the vocal cords or much neck manipulation. Indications of intubation is either mainstay airway patency in the trauma situation, or during the inability to maintain an adequate saturation by face mask oxygen, or a head injury to prevent aspiration. Whether the tube is placed correctly is assessed by bilateral rising of the chest during inspiration, by auscultation and improvement in the patient's vitals. And also we see its presence in a CO2 detection device that is attached to the bag mask device indicated by the color change. If the intubation is successful, then cervical collar is reapplied. If nothing else works, then either a needle cricothyroidectomy, a surgical cricothyroidectomy, or even a tracheostomy may be required. In cricothyroidectomy, the patient is ventilated with a cannula plus a Y connector, which intermittently there is insufflation for 1 second and then relaxed for 4 seconds. This may lead to CO2 retention in a head injury patient. Thus, the indications of cricothyroidectomy are limited to the patients who have a normal breathing pattern with an airway obstruction. Risks include dislodging of a probable impacted blockage that at the glottis into the hypopharynx that may lead to iatrogenic barotrauma causing a tension pneumothorax. If the patient is not intubated, despite multiple attempts, he does require intermittent bag mask ventilation intermittently. When the patient is successfully intubated, a ventilator is connected along with volume and pressure regulation. Depending on the equipment, the clinician should be aware of the gradient change of intrathoracic injury that may convert a simple pneumothorax into a tension pneumothorax. Pulse oximetry is used to detect hypoxia. It shows probably oxygen saturation, which serves as a good indicator. A final few words on pulse oximetry. It is used to measure the oxygen saturation of blood. Many of us do not understand this concept. Let me probably explain in blood, and it's probably the concept of hemoglobin is that is quite important, and it's a key molecule that is present in blood, and its main function is to carry oxygen. Every molecule of hemoglobin has a capacity to carry 4 molecules of oxygen. These molecules are carried into blood and they generate a pressure along with other components that is termed as a partial pressure of oxygen. The partial pressure is the defining factor of ventilatory mechanics and respiration, and is formed depending on the number of oxygen molecules present. For example, a person respires at the rate higher when he takes a run. In a situation of crisis, it is the partial pressure generated that determines how the body is responding, and so if it is a strong reflection of the changing situation. Saturation, on the other hand, doesn't fluctuate that grossly like partial pressure, and so even critical fall in the partial pressure doesn't show up much by saturation. But for all practical purposes, 95% oxygen is taken into consideration, and it indicates 70 mm mercury of partial pressure, which we measure in an arterial blood gas. This measure holds sensitive in trauma settings. Similarly, partial pressure of carbon dioxide or the end-tidal carbon dioxide determines the way the ventilation takes place, and that too is measured by the arterial blood gas. With this, I conclude my talk. Goodbye and see you next time. If you have any queries, insights or experiences, please feel free to write in the section below. If you have liked this video, give a thumbs up or subscribe to my channel for more of such videos.